So I'm sure you guys have seen our notes and you're like, what are they talking about? Because we use a lot of abbreviations. So the first thing I thought I'd just talk about is interpreting our note. So this is a general, I just grabbed this off something called optobook.com. It's a pretty good basic tutorial of ophthalmology. I read it as a med student, but it has really good samples of everything. It explains things very well in a simple way. So HPI and all this stuff on the side, the past medical, past ocular, family history, allergies, meds, you all understand all that. So right here in the middle, though, this is so we don't take vital signs like you guys do. We don't check blood pressure, heart rate, all that. We don't do that in clinic, and really, I don't think I look at it unless the patient has something like hypertensive retinopathy, and then I just tell you guys to get it under control. So our vital signs are right here in the middle, this vision, pupils, tonometry, which is just pressure inside the eye, visual fields, and motility. So this first one is just V. It stands for V, or you'll see it as VA, visual acuity, and it'll either have a CC next to it or an SC, and that's just CC's with correction, SC's without correction, and then you might see an N for near or D for distance. And by the way we always do it is we always do right eye on top, left eye on the bottom, and right eye is OD, left eye is OS. But if you don't see that, it's always, right eye is always first. The second one here is P for just pupils. And again, we don't do the PERLA, the pupils equal round reactive to light, because that doesn't really tell us too much. So we just write down what it goes to with light. So it started out at 5, went to 3, the other one did the same. But the main thing, and you probably can't read this here, but it says no APD-OU. That's the most important thing. You might see R-APD or just APD, and that stands for relative afferent pupillary defect, which is that swinging flashlight test from med school. And that tells us the most about the eye, and if there is, say, an afferent pupillary defect, if you shine a light in one eye, both eyes will constrict, and then you take that light and swing it over to the other eye. Again, if it's normal, both eyes should constrict. There should be a slight dilation in the time the light is swinging between the two eyes. If for some reason one eye is dilated, but someone put an eye drop in only one eye, and you only have one eye that's reacting to light, you can still check an APD of both eyes, because the way that pupils are wired, it's a consensual response, and there's a double crossover in the way the optic nerves go back to the chiasm, and then again in cranial nerve 3. And then this over here, the T is for tonometry, and it's usually just like TP, so that's applanation tonometry, and we use a tonopen, which is this little thing here. We numb a patient's eye up and touch this to the front of their eye, and it tells us the pressure. It basically is some fancy formula that however much force it takes to flatten a specific area, it'll correlate that to pressure, and this will tell us how sensitive it is. It gives us a range if it's 95% accurate, 90% accurate, and it does a range from anywhere from 2 millimeters of mercury all the way up to 50. And then CF is just confrontational visual field, so you might see CVF, and that's just where we're holding our hand over one eye and holding up fingers. EOM is just extraocular motility. OU is both eyes. So SLE, that's for slit lamp. You'll never see that in the hospital unless it's in the ER. We'll usually just put PLE, which is pen light exam, which is just us looking with a light, and maybe some of our lenses are indirect. Getting down to here, so on this, it's external exam. L&L is lids and lacrimal glands. CNS is conj and sclera. K is for cornea. I don't know why it's not a C. It should be a C, but anyway, we put it as a K. AC is anterior chamber, so the space between the cornea and the iris. Iris is iris, lens, and then vitreous. Over here is just what we would say if we saw an abrasion or a drawing. We would make a circle and say where the abrasion is, so that the next person that sees this patient or whoever, either on call or in the clinic, will know if it got bigger or smaller. We'll measure it, say it's 4.5 by 5 millimeters. I typically don't do this. This is supposed to be an anterior-posterior view showing how deep it is. And with a slit lamp, we're able to say what the depth is of how far any lesion is. And then you'll see these drawings all the time. DFE is just dilated fundus exam, and by this we'll say typically when we dilated them and what agents we used. For adults, it's always M&N for Madriacil and neosynephrine, but don't worry about that. We'll just put the time down. If their eyes are dilated, it can last up to a day, and that's normal. So if a patient says, hey, eye doctor was here, I can't see anything up close. Eyes are all dilated. That's normal. So in here, we always do our drawings. There'll be an X in the middle, which isn't on these. The X in the middle is the macula. Then you have the optic nerve and the vessels just coming off. We only draw the major vessels, the major arcades, and I'll show you more photos. A lot of times we won't even draw this unless we're in our clinic. The smaller one is supposed to be the optic nerve, and we'll give a cup to disc ratio. So the cup is like the overall diameter, or actually the cup is the inside and the disc is the overall diameter. So this is like a third of the size. So 0.3 cup to disc. Increased cup to disc ratio is associated with things like glaucoma suspect, and they'll have typical appearances. And then just macula vessels and periphery, we'll just typically abbreviate that MVP. And if you see these drawings and they have dots, we'll try to label them. They'll either be blood or laser scars are always X. So we'll do laser on patients for diabetes, and I'll have photos of that. But that's basically our note. So a lot of abbreviations, and I probably didn't cover half of them. We have a lot of medications where we use abbreviations. So like AT for us is artificial tears, and I know it's a pain for every other service, but we basically just abbreviate as much as we can. So just getting into the actual talk. So diabetic retinopathy, you guys see, or you see diabetes all the time. Retinal complications from diabetes is a leading cause of blindness in the working class. So here's a photo. This would be at the left eye, and the vessels here all look normal, but this is pointing to an MA. I don't know if you can see this, but there's a little dot here, a little dot of blood. So that's a microaneurysm, just an outpouching of a very small vessel. There's another MA, and they're kind of around, and we just, again, more abbreviations. These yellow areas here are hard exudates. That's just where you get leaky vessels and it leaks fluid. And then when the fluid gets reabsorbed, the lipid is still there. So it'll stay here for a long time, and, eventually will get reabsorbed by macrophages. Just looking at this photo, you'll see a lot more of these. So this is the optic nerve, and these larger vessels are the arcades. And the way they look, you can tell the difference between veins and arteries. Arteries are about 2/3 the size of veins. And then in the middle here, there's actually no blood vessels where it's a little darker, and that's going to be the macula. And in the very middle of that is the fovea, where you'll get your 20/20 vision. So more things of diabetic retinopathy. You can get, along with the microaneurysms, which you can see as these little dots of blood, you can also get different shapes and sizes of bleeding. So we'll call it like dot blot hemorrhages or flame hemorrhages. And this is also a cotton wool spot here. All of the bleeding, it's just intraretinal bleeding, and the different shapes are dictated based on where the bleeding occurs. So if it's a flame-shaped hemorrhage, and this isn't a great example, a lot of times it'll be radiating out from the optic nerve. It's a superficial, it's in the nerve fiber layer of the retina. I'm sure from medical school you all remember there was like 10 layers of the retina. So superficial ones, they follow the track of the nerve fiber layer. And then dot blot is just deeper. Other things, like when diabetes gets bad, you can get neovascularization, and that's the main thing we worry about, and we actually start treating with laser injections and everything else and doing surgery. So right here is your optic nerve, and this is NVD, or neovascularization of the disc. It looks like a lacy, like fishnet almost, of blood vessels, and these are just abnormal blood vessels from hypoxia that develop. And then we also have NVE, which is neovascularization elsewhere, which is basically anything that's not on the disc. And these are more extreme stages. So with diabetes, diabetic retinopathy, the stages it goes through is mild, moderate, severe. Mild and moderate is pretty subjective. If there's a few, like if I see any blood anywhere, 1 MA, it's mild. If I see a little more, it's moderate. But then when it gets to severe, we actually have rules we follow that we look at when we dilate. So it's like this 4-2-1 rule. And so you either have any one of these criteria. So 4 quadrants of hemorrhages or microaneurysms, 2 quadrants of venous beating, or 1 quadrant of IRMA, which is intraretinal microvascular abnormalities. And basically, this IRMA thing looks like a neovascularization complex, like an NVE, but it doesn't leak when we do a dye test called an FA. So the vessels just look like neovascularization. And this is all this severe non-proliferative is important because 15% will progress to proliferative PDR in 1 year, proliferative diabetic retinopathy. So that means basically PDR means if they have any NVD or NVE or any vitreous hemorrhage caused by either the NVD or NVE. And then if they get very severe NPDR, which is 2 of the above criteria, they have a 50% chance of progressing to PDR in 1 year. So that's just, like I said, PDR is just neovascularization of the disc or elsewhere. Now, the treatment, like the gold standard that was done all the studies of what do you do when they get PDR is you laser their eye. You basically use an argon laser and you're killing off peripheral retina where people get their peripheral vision. And you're doing that because you're going to decrease the hypoxic drive for the retina. So in diabetes, microvascular disease, the retina isn't getting enough blood flow. So it sends out molecules, VEGF, and VEGF causes new blood vessels to form. So with laser, what we're trying to do is kill off the periphery, and basically the blood supply they have left will be adequate for the macula and the area where you actually get your vision. And most patients that we laser will laser pretty much right up to the arcades, and I have a photo of it coming up, but most people don't notice a difference in their periphery vision because you're not using your periphery all that much. But anyway, if there's a high risk PDR, there's specific criteria again, and this is when we typically start lasering patients. So if they have neovascularization of the disc greater than 1/4 to 1/3 disc diameter, any NVD with vitreous hemorrhage, or any NVD greater than a disc area with vitreous hemorrhage. Again, this is nothing you guys would have to know. Just if they have diabetes, send them to us and we'll laser them if they need it. So this, again, optic nerve, these burns here, these are chorioretinal scars from laser. And so the macula is over on this side, and this is just a fundus photo focused on the optic nerve. So on this, like, we will take our laser and we'll come pretty close to the optic nerve within a disc diameter. Everything when we talk about in the eye and in the retina, we always talk about like disc diameter. So what we're talking about is 1 optic nerve disc diameter. So we'll come within a disc diameter of the optic nerve with the laser. If we come closer, risk of, scotomas and decreased vision. If you hit the optic nerve, that's not good. If you hit the fovea, they go blind and don't see. So if we don't catch them early enough and they develop PDR, you can get vitreous hemorrhage, you can get retinal detachments, which is, this is showing. So there's abnormal blood vessels, there's fibrosis, and this looks like pre-retinal fibrosis because you can't see any of the architecture underneath of the normal retina. But this is the optic nerve, and these are just abnormal blood vessels. So someone like this would need surgery. Laser wouldn't do anything at this point, and the surgery they'd probably have to get would be a vitrectomy. So this is just a photo of what a vitrectomy kind of is. Basically, we have these ports. They're like anywhere from 20 to 25 gauge needles. And we do, there's typically 3 of them. There's an infusion port. This is only showing 2 because it's showing the vitrector, which is here, along with a fiber optic illumination. But typically we'll have the fiber optic separate. And that's how we'll do a vitrectomy, where we just take all of the vitreous out. And one of the things that's doing for people with proliferative diabetic retinopathy is that you're removing the scaffolding where these abnormal blood vessels grow. And if you do that, even though they'll still have the VEGF drive, the main thing is you want to eliminate these abnormal blood vessels from growing in the vitreous, because what they'll do is grow in the vitreous, they'll bleed, cause vitreous hemorrhage, and then it can also contract and cause retinal detachments. One thing that wasn't in this talk, and I just added some slides because I think this talk was from one of my attendings from many years ago, but diabetic macular edema is another one of the main causes diabetics can get decreased vision. And this is called an OCT, or optical coherence tomography photo, and it's basically like an ultrasound of the eye, and this is the layers of the retina. And so there's 10 layers. This would be the front, and this would be the back, and you can even see parts of like the RPE and the choroid back here, and up here in the black is just vitreous. This is normal. This is a flat retina. Here's your fovea. This little elevation here is actually just an artifact from the rods, or actually from the cones being so tightly packed together. It just makes it look elevated, but it's not. When you get really bad diabetes, you can get diabetic macular edema, and they can get this even without like proliferative changes, without neovascularization, and you get these clefts or cystoid spaces caused by leaky blood vessels. And the main thing is that this layer right here is called the ellipsoid layer, and that's basically your photoreceptors. If this gets elevated in the middle, it's okay underneath it as long as this layer stays intact. But once this starts getting disrupted, you're destroying photoreceptors and your vision gets worse. So the treatment for this isn't surgery. We do injections of anti-VEGF molecules into the eye. We can also do like steroid injections. Patients that get this, they can get injections up to once a month, depending on what injection we use. Some of them are depot injections that last anywhere from like 3 months or longer. But these are the drugs like Avastin that is used for GI cancers, and it's the same exact drug. We just use a much smaller quantity. And then they have the other drugs like Lucentis you might have heard of. It's pretty much the same thing, but costs $2,000 per shot, while Avastin only costs about $100. So from your all standpoint, diabetic retinopathy prevention is the main thing. Optimal long-term blood sugar control with annual dilated fundus exams. Per our books, it says type 1 diabetics can wait about 5 years before they get their first dilated exam. Type 2 diabetics should get one immediately as soon as they're diagnosed with type 2, and then about every year after, maybe every 2 years, depending on what their initial exam shows. Any questions about diabetic retinopathy? No? All right. So sickle cell anemia, another thing, you can get sickle cell retinopathy with this. So the prevalence of sickle cell retinopathy actually goes by the genotype. So SC is the most common, S-thal is the second most common, and people that have both sickle cell genotype, they're actually the least common to get it. But this also has stages, so stage 1 through 5. Stage 5 in anything in ophthalmology is always the worst. It's always, retinal detachment with traction. And right before that, stage 4 is always vitreous hemorrhage. But here, the first thing you'll see is arterial occlusions and then peripheral anastomoses. Stage 3 here, you get neovascularization, again, just from occlusions, and it's called C-fan neovascularization, and I have a photo to show you why. So here, these arrows are pointing out just the vessel occlusion. So when vessels get occluded, they basically start looking white and sclerotic. So any retina out here is basically non-viable. This would be C-fan neovascularization. Looks like a C-fan, and this is at the border where you have perfused retina and non-perfused. Other things in sickle cell anemia that you can see, and this is something called a sunburst, and it's caused from chorioretinal scarring after the patient's had intraretinal hemorrhage from vessel occlusion. Another thing you'll commonly see is something called a salmon patch, and this is just intraretinal heme, again, from vessel occlusion. So with sickle cell, it all deals with vessel occlusion. Next topic, hypertensive retinopathy. So this is just a patient here has cotton wool spots. Their vessels look attenuated. You can see the veins look a lot larger than the arteries. It's probably like a 2-to-1 ratio. And they have something called silver wiring where you get attenuation where when you shine light in it reflects back and it looks like more of a silver wire. There's something else called copper wiring where it's not as severe, but again, not that important for you guys. People with hypertensive retinopathy will get these exudates, flame hemorrhage here, and when it gets real bad, you can get disc edema. So again, like everything else, we have staging. There's different staging by different names, but it starts out with minimal constrictions and gets worse. Eventually, you'll develop bleeding with hemorrhages and cotton wool spots. But the thing with hypertensive retinopathy, the worst stage in each of these is when you get disc edema. So here, disc edema can be seen because you get blurring of the margin. Vessels start getting obscured when they go over. And here's a photo. Again, cotton wool spots, flame hemorrhages, possibly a little disc edema, but this isn't a great photo. Here is, again, same thing. You get hard exudates, silver wiring of the vessel, so attenuation, tortuosity of the veins, flame hemorrhages, and edema again. So only treatment for this is just control the blood pressure. Next thing, thyroid eye disease. So with thyroid eye disease, it's the most common cause of any type of ptosis or lid retraction, and it can cause strabismus and other issues. So on CT imaging, or any type of imaging, the main thing you'll see is enlargement of the extraocular muscles in what is the muscle belly, but it spares the muscle tendons at the insertion into the eye or onto the eye. So it'll look very fat in the middle, but then it gets to normal size over here. And on a coronal view, they just look very large. Not important for you, but the muscles that are typically involved would be like medial, rectus, then inferior, lateral, then superior. So again, you'll get this look of just lid retraction. And if a patient's just looking at you normal and you're able to see the sclera above, without them like opening their eyes wide, that's technically lid retraction. And this person's looking straight, so they have some strabismus. When those muscles get really large, they can cause abnormal deviation. So this person might be looking straight, but one of their eyes will be deviated upwards. And the other thing is they'll get motility restrictions where they won't be able to move their eyes in all directions. This is the worst case scenario where they get exposure. So they get retraction so bad that their eyelids can't close and they get thyroid exposure keratopathy. This is just from not being able to blink. Because when they close their eyes, it's just not getting coverage. So this is what we try to prevent. If we ever see anything like this, the first thing we'll do is put a tarsorrhaphy in. We'll just close the eyelid with a suture, straight across mattress suture to close the eyelid and hope the cornea gets better, because you worry about long-term damage from corneal scarring, and that would require other surgery like corneal transplants. One of the emergencies with thyroid eye disease, and thyroid eye disease is fairly insidious when this happens, but you can get optic neuropathy from it, where this is just, you get disc edema. And so like if you look here, this is a cut. I think it's obviously not where the optic nerve is showing, but the muscle bellies are so large here that the optic canal towards the back is so small that if the muscles enlarge that much, they're going to put pressure on the optic nerve and you can cause an optic neuropathy. If that happens, it's like an emergent surgery to do a decompression where we'll just take part of the orbit off to give room. So we'll do an orbital decompression. Treatments normalize thyroid eye levels, and even if you do this, the symptoms can still get worse because it's even people that are euthyroid can still get progression of their thyroid eye disease. You can do steroids and radiation. If you're going to do surgery for these people once they're stabilized, there's a specific order you want to do it in, because if you do an orbital decompression, it will affect the eyelid position. And then the next thing you would want to do also is, in the specific order, you would actually do muscle surgery second and then lid surgery last. Because each of these surgeries can influence the position of the lids. So if you were to do lid surgery first and then do a decompression, you can cause them to have ptosis or lid retraction. And then you'd have to go back and do extra surgery. Continuing onward, inflammatory conditions, you guys see a lot of, I'm sure. Sarcoidosis, rheumatoid, juvenile RA, lupus, and ankylosing. I'm just going to hit on some of the things that you guys might see if you're looking at them. Obviously, you don't have slit lamps, but if you're just looking at the eyes and things you might see. So with sarcoid, affects African Americans and Hispanics more. 25% will have ocular involvement. Things that we most commonly see ocular involvement with sarcoid will be any type of anterior uveitis or iritis. By definition, you would see like cell and flare, which is basically you would see white blood cells, and flare is just protein in the anterior chamber. You can't see that without a slit lamp. This here is just showing ciliary flush, where you just have engorgement of the conj vessels right up to the limbus. Here is more advanced inflammation of the anterior chamber. These are KP or keratic precipitates, and with sarcoid you get these large KP, and these are just aggregates of inflammatory cells, so like white blood cells that aggregate, and they're called just like mutton fat KP because they look greasy and stuck on, and sarcoid will have this bilaterally if it's real bad. Other than that, they can also get scleritis. So scleritis and episcleritis can look very similar. Textbooks always say that scleritis has a purplish hue to it, and some of our dilating drops will like blanch the vessels, but with scleritis it won't. With scleritis, there's always most commonly an underlying cause. The most common is rheumatoid arthritis, but sarcoid can cause it as well. Here in sarcoid, another with all the inflammatory conditions, if it involves the posterior of the retina, you guys, unless you're dilating them and looking with a direct, you're not going to see this type of stuff. But this is a periphlebitis, so just along the vessels. And in this person, they also have some granulomas in the retina. But again, just more manifestations of sarcoid in the eye. And sarcoid can cause a pan-uveitis, where it's just inflammation of all three layers of the eye, so the anterior, the intermediate or vitreous area, and also the posterior, which would be the retina. So malignancies in the eye. So you got primary ocular melanoma, large cell lymphoma, and metastatic. The most common malignancy in the eye is metastatic, with lung, breast, and prostate being, in that order, the most common. And then after that is melanoma, malignant melanoma. Then I think the most common primary tumor of the eye is primary ocular melanoma. So what we see, if we see tumors and they're metastatic, you'll see, so there's the optic nerve, and this large subretinal yellow lesion. Obviously, just on a photo, the only way you can tell it's subretinal is that blood vessels are going over it. But if we're looking under slit lamp or using our indirect with our lenses, you're actually able to tell depth, because with stereo, that's the reason with our slit lamps and everything, you're able to see the depth of things, so you can see if things are elevated or where they're actually located. So this would actually look like it's jumping out at you. Treatment for these, local radiation, chemo, brachytherapy. You can do eye wall resection, which I've never seen, and then enucleation, depending on which type of malignancy it is. Other things, so AIDS, ocular manifestations would be dry eyes, cotton wool spots, CMV retinitis, and Kaposi sarcoma of eyelid or conj. So this looks pretty much like a diabetic might or a hypertensive. It's just got some cotton wool spots. This patient would probably have some MAs or blot hemorrhages, but just based on the history, if they have an HIV, a lot of these patients come to our clinic because HIV patients will get yearly dilated exams too, and if they have diabetes, it's tough to tell what it really is, because it could be either. They look the same when they're early on, but depending on what their CD4 count is, the main things we worry about with them is things such as CMV retinitis. So this would be CMV retinitis. CMV retinitis only happens, I think, when the CD4 count's below like 100 typically. So you're getting CMV retinitis. This would be called like pizza pie retinitis. I always describe it like that because the white areas are just necrosis, and then you have blood. And they have different names for it. There's one called like brush fire CMV retinitis, where it literally starts in the periphery and it just goes across the whole eye fairly quickly over the course of a few days. And the main thing on these is that just treatments for it is like ganciclovir is the only thing that'll work for our ocular. Ganciclovir and foscarnet are the only ones that'll work for CMV retinitis. And you can also do intravitreal ganciclovir, but we typically try IV first. And again, there's also implantable pellets that we can do an injection in the eye, and it'll do a sustained release. Like I said, CD4 count, less than 100. We're thinking opportunistic infections, and greater than that, we're thinking other ocular infections that they might be susceptible to, like syphilis. And basically, with anything in the eye, we always think about syphilis because it can, like everything else, everything else in the whole body, syphilis can present as anything. So that's always on our differential. HSV keratitis, I'm sure you guys have seen this, this dendrite pattern. So you get branching off with terminal bulbs. And HSV keratitis and VZV keratitis can look a lot alike, except they say that VZV keratitis doesn't have terminal branching, and they're actually pseudodendrites, because there's not actual loss of epithelium on the cornea. And typically people with VZV keratitis will have shingles, or they'll have the typical distribution. If anybody has shingles if it's on the tip of the nose, that's called Hutchinson sign, and I'm sure you all have heard that, but that's much higher incidence of ocular involvement. And of these, VZV compared to HSV is much worse for things as far as causing retinal damage and permanent vision loss. Giant cell arteritis, this is one of the true ophthalmic emergencies that we worry about. If you guys ever get to see a patient with this and have a direct ophthalmoscope and you look at their nerve and it looks chalk white, it's described as a chalk white or pallid edema, disc edema. Not many things cause that, but GCA is one of them. So we always think, if they're greater than 65, Caucasian, jaw claudication, weight loss, anorexia, neck pain, fevers, headache, scalp pain, myalgia, vision loss, and diplopia. The testing we do, ESR, CRP, CBC, and these are just for inflammatory markers. We're looking for platelets greater than 4,000 here. The ESR, we don't go by what the lab gives us. Our criteria is for males, it is whatever their age is divided by 2. If it's higher than that, then it's high. So 70-year-old, if it's greater than 35, it's elevated. For females, it's age plus 10 divided by 2, and that's what we go on. And that's actually been shown to be pretty good if you monitor that, the response to treatment. And then temporal artery biopsy. So if everything's normal, but we have a high suspicion, we'll get our oculoplastics doctors and we'll do a temporal artery biopsy. And they'll typically take a pretty good section of about I'd say at least a few inches because of the skip lesions. And even if that's negative and the suspicion's still high, they'll probably biopsy the other side. Because it's not something we're going to want to miss, because if we miss it and don't treat it, they're going blind within a day or two.
Why do you think
it's more of the optic neuritis, GCA, but the muscles aren't involved. It's because you get your nerve involved. If you get nerve swelling, it can cause it. I know that's not a great answer. But no, you can get the muscles involved from the small vessels, but, with GCA, you typically think larger vessels. So the treatment is prednisone, 1 ml per kg per day. Always add a PPI or H2 blocker for GERD. If the symptoms persist, then we go to methylpred. The treatment on this, the taper, is forever. And again, we follow it, the ESR, corrected for age. Optic neuritis, go ahead. Yeah.
Your first temporal artery biopsy is negative. Do you repeat the other side?
We will if there's a high suspicion.
What if they're both negative?
Then we'll probably treat to see if it gets any better. It's all patient to patient, just like everything else. But that's why when we have our oculoplastics doctors do it, they just take large sections. We've had some that this year that both have been negative, inflammatory markers were negative, and we still treated and the vision got better. But we'll err on the side of caution and treat if there's a high suspicion. Optic neuritis. So with optic neuritis, there can be, there's a few classifications we use, but for your all's sake, I probably don't have to get into that. But there's anterior, there's arteritic and non-arteritic. So GCA would be an arteritic type, and then non-arteritic anterior ischemic optic neuropathy. They have different risk factors so what we call an NAION, non-arteritic anterior ischemic optic neuropathy. This doesn't deal with optic neuritis. So GCA, we already talked about the risk factors, but so this is the arteritic form. The non-arteritic form, the risk factors are things like diabetes, high blood pressure, and then the way the optic nerve looks. So an optic nerve, everybody's optic nerve looks different. Some are bigger, some are smaller. People with non-arteritic, they always have what we call a disc at risk, where they have a small optic nerve and a very small cup-to-disc ratio. So where the optic nerve penetrates through the lamina cribrosa, it's a very narrowed area, and it's more of a microvascular thing. So that's just the other differentiation between arteritic and non-arteritic anterior ischemic optic neuropathy. And then there's a third type that's a posterior ischemic optic neuropathy where everything looks normal and it's just behind where we can see it. So optic neuritis, the symptoms of decreased vision and pain with eye movements, and not everybody will have pain with eye movements. For this we treat if it says if visual acuity is less than 2200, but we typically treat if there is probably even 2100 to achieve faster visual recovery and also decrease the conversion rate to MS. If there's significant visual loss, like to 2200 or worse, we'll do IV. Otherwise, we might just observe. But the main thing on optic neuritis is there was a study done, the optic neuritis treatment trial, that showed that you never start PO prednisone on these people because there's a higher rate of conversion to MS initially. But if you start with IV and then transition to PO, there's not an increased risk of MS. And we also get a MRI looking for plaques, because if there's like any periventricular white matter lesions, so all people with optic neuritis, I think they say the rate, no matter what, there's a 30% chance they're going to develop MS at 5 years. If they have no lesions on MRI, it goes down to something like under 15%. If they do have a lesion, it goes up to like 50%. I don't remember the exact stats off the top of my head, but they followed this out to like 15 years. And I think they said the overall risk of anybody with or without MRI is about a third. So